Hey guys, I wanted to put out another short podcast to talk about CPR and vasopressors in a trauma arrest. There's been some things coming out lately and a little bit of controversy, although I think the vast majority agree on the uselessness of CPR and vasopressors in a trauma arrest. So we're going to talk about that a little bit today. So obviously they have very poor survival rates. I've seen different figures from 0 to 17 or so percent. Most of the causes, obviously head trauma, exsanguination, and your obstruction, tension pneumos, and pericardial tamponade. And let's not forget about airway issues with hypoxemia, which is usually easily fixed. Patient usually presents in PEA, meaning their heart is still beating. It's a trauma arrest, so they most times have a nice strong heart. It's just that they don't have anything to work with, which we'll get into later. The management, of course, you want to identify them early. If it's a trauma arrest rolling through the doors of the EMS, it's usually pretty obvious because they're going to be doing CPR, which is fine. Pre-hospital, there's not a whole lot of other things they can do. If they haven't arrested yet and they're hypotensive, tachycardic, etc., that's the time to try to fix them, but we're not going to get into that since that's not the subject today. So what can we fix? We can fix hypoxemia, obviously, secure the airway. We can hopefully fix hypovolemia, which is from exsanguination. They're either hemorrhaging internally or externally, and they need cold steel, tourniquets, pressure, etc. Tension pneumo, as well as cardiac tamponade, are your obstructive reasons that we can fix. So as I mentioned, the airway, it's an easy fix. Intubate, you can even use a supraglottic device like an LMA, King tube, whatever. Hypovolemia is pretty much always due to hemorrhage, either internally or externally. If you have a general surgeon, then they can help you out with the internal part. If it's external, then direct pressure, early use of tourniquets, etc. Aggressive resuscitation with blood products. I can't say that enough. Not crystalloid. They're in the ER. They should be getting blood products, not more crystalloid. You want to try to do a 1 to 1 ratio of packed cells, FFP, and platelets, unless you're in a part of the country that has fresh, warm, whole blood, which is pretty rare right now, but that's obviously the best. And I just want to mention again, not crystalloid. If they're in your ER and you're given crystalloid, then 99.9% of the time you're wrong. You should be given blood products, whether it be O-POS or O-neg, type specific, until you can get them typed and crossed. If you do have to give crystalloid because you don't have any blood products, then small aliquots of 250 cc's at a time, and judge their perfusion. Don't just go by blood pressure, because if they're warm and perfusing with a MAP of 45 or 50, that means that I will probably hold off until I do have blood products, because there's no real reason at that point giving them crystalloids. On the other hand, if they're cold and you can tell that their periphery is shutting down, then you may want to bring that pressure up a little bit until you do get the blood products. Tension pneumo, needle decompression, finger thoracostomy. The finger thoracostomy is far preferable. Needle decompression, especially the old way, anterior second intercostal space, 65% success, a lot of complications. A lot of times it's put into medial and you're hitting vascular structures and so forth, not good. The new ATLS has changed to mid-axillary line, where the same place that you put the chest tube in, or do a finger thoracostomy. If you're going to put a needle in, you might as well just do a finger thoracostomy. It's very fast, it's very easy, and it's 100% successful, meaning that you get into the right space 100% of the time, not that you save them 100% of the time. If you get a trauma arrest that comes in, don't wait. Don't do a chest x-ray. Don't do an ultrasound. Just do it. Make it one of the first 1 or 2 things you do. Scalpel, cut, um, use your hemostats, pop in through the pleura, and or pop in through the chest, sweep your finger around, and switch the other side. A pericardial tamponade, ultrasound to diagnose, um, and obviously a thoracotomy. If you don't have a trauma surgeon, then a pericardiocentesis using ultrasound guidance is the best. Thoracotomy, um, many of us are in rural areas. That's just not going to happen. I'm in an area where we don't even have a surgeon, much less a trauma surgeon. We have no specialists. We just have family practice providers. So this person would not be getting a thoracotomy. So you have a blunt trauma arrest that comes in, no pulses, no cardiac activity. So you don't want to do CPR. You don't want to do ACLS meds. Let me repeat that. No CPR, no ACLS meds. You want to fix what can be fixed. The chance of you fixing anything is extremely low anyway in this particular instance. But the things you can do are airway, which if you're the only one, you can defer that. Number two comes a bilateral finger thoracostomy, rule out tension pneumo. This is by far the thing that saves patients the most. It takes 30 seconds to do a side. After that, put the ultrasound on the heart, look at it. If there's pericardial tamponade, fix it. Is the heart beating? If it's beating, then start pumping in blood products. If it's not beating, it's time to call the code. Don't give epi, don't do CPR, don't do anything else. Just call it. That patient is dead. A penetrating trauma arrest, obviously the highest survival rate. If it's recent in under 10 minutes, then thoracotomy is indicated. But again, if you're in a rural area, that's not going to happen. So you try to fix what you can. PEA, pop in a chest tube to the affected side, get the blood out, relieve a tension pneumo if there is one. Obviously consider blood products. More than likely going to have to do a massive transfusion with the platelets, FFP, and packed cells. And don't forget to rule out other causes such as tamponade and make sure that that's not going on. So on to why no CPR. I posted a couple of videos recently discussing it, and I'll go into why the actual physiologic reasons near the end. But right now, the studies show there's no benefit in trauma arrest. You may worsen coronary perfusion, limited provider access. So if you're trying to do procedures, CPR just gets in the way. You want to put a chest tube in, you want to intubate, you want to needle them, you want to do pericardiocentesis, you want to scan the belly. CPR just gets in the way, and it's not doing anything, and it's doing more harm than good. The one caveat on a medical code that causes the trauma, it's rare, but if you get an elderly person in that you think may have had a medical code that caused the car accident or whatever, just keep that in the back of your mind. If you suspect that, then obviously you're going to want to do ACLS on that person. But that's the only instance. Well, I don't want to say only, but 99.9% of the time, that's the only instance. If the heart's in standstill, just call the code. This is a blunt trauma that comes in, and EMS is doing CPR. Pop the ultrasound on, heart's in standstill, and you've done the 4 things you could do, then just call the code. If heart shows PEA, then the heart's beating. CPR is going to inhibit that further. It's not going to help. It's not going to help the heart. You have a strong heart that's beating, but it has nothing to work with. If they've exsanguinated or they're very low on blood volume, the heart's already beating, you pumping on their chest is not going to do anything at all. If there's an obstruction such as a tension pneumo or pericardial tamponade, then CPR is not going to help. It's just going to inhibit that healthy heart from pumping even more so. We just go back to that. It's if you envision it, and really once you think about it, it all makes sense, because if you have no blood, then CPR is not going to push anything. If you have an obstruction, CPR is not going to push anything. You have to fix what's causing the issue. So why no vasopressors? This is so ingrained into us, especially anesthesia providers, because you grab the levo, you grab the epi. Multiple studies show no evidence at all to support the use of ACLS meds like epinephrine and norepinephrine. It increases mortality. All the major organizations, ATLS, etc., don't um, tell you that this should be done. There's many, many studies. I've included the references at the end of this podcast. From up to date, I copied and pasted here. Vasopressors, there's not a single human study that supports the use of vasopressors in the resuscitation of an adult with trauma. It actually may be harmful. The only exception is in neurogenic shock, and usually those patients aren't coding, it's just that they're hypotensive, etc. And of course, then you can consider the use of Levophed or whichever vasopressor you like to use. MD Edge um, did a large study, reviewed a large study, like 6,000 patients. Don't quote me on that number, but it was really big, and found vasopressor use in the first 24 hours of a trauma case was associated 11.5-fold increased risk for death. That's huge. I've seen other studies that say an 80% increase. Bottom line is vasopressor use increases mortality in trauma. You need to fix what's causing the hypotension. Now, there are some proponents that say, well, after they're resuscitated, after you've given the blood, you've volume repleted them, you've fixed the obstructive issues, you've stopped the bleeding. In that case, some patients take a while to reset, so to speak. So you may want to consider the use of vasopressors, but again, it's not something you should be thinking about in the ER for sure, or in the OR. There's a large military study, and dickyricky.com published it. It's just an outstanding read. I put the link here. Go and read that. It's just excellent. Talks about CPR, trauma, vasopressors, etc., and how the military has really opened our eyes to a lot of things and changed the way we think about a lot of things. Here's some references, a bunch by GEMS, role of epinephrine, different trials. Basically, it shows what I've already talked about, that it does no good, just increases mortality, increases damage. So fix the issue, don't push pressors. Here's a trauma rest algorithm that I love. It's just fantastic. It's a little beyond what most of us do. None of us, well, I won't say none of us, most of us, unless you're a trauma surgeon or a residency trained ER physician, intensivist, won't be doing thoracotomies. But the first half is really, really good. So you have a patient in cardiac arrest. If it's a medical cause, which is very rare, obviously go to ACLS as well. But generally it's going to be no. Loss of vital signs. If it's over 10 minutes and they come in arresting, then you can consider just stopping right then. I would do the few things that you can reverse. Number one is good practice. Number two, well, you just never know. If it is under 10 minutes in a trauma arrest, if it's blunt trauma, you can see external compression is optional. The vast majority of the trauma experts that I have been listening to just say forget it, don't even bother. So that's the side of the fence that I'm on. And we talked about the physiology. And they suggest what I discussed, obviously, hemorrhage control, blood to resuscitate them, the airway, obviously bilateral finger thoracostomies, and go on from there. If it's penetrating trauma, airway, obviously again open finger thoracostomies, do the most injured side first if it's a stab wound, gunshot, etc. If there's no ROSC at that point, obviously you're going to be giving blood products as well. You really need a surgeon. If there's ROSC, then you need to get them the heck out of there if you're in a rural area, or get them to the OR to a surgeon. Also consider tranexamic acid at that point. continue your massive transfusion protocol and so forth. So you can go down to either side. The blunt trauma is pretty much the same. We discussed that. If you, after doing the four things, you don't get ROSC, check for pericardial effusion. No pericardial effusion, no cardiac motion, call it at that point. The patient's dead. If there is cardiac motion on ultrasound, then continue volume resuscitation, meaning blood products, not crystalloid. And you have a general surgeon, trauma surgeon, get them there, then maybe they have a chance. Otherwise, it's not a whole lot of hope. Tranexamic acid, obviously massive transfusion protocol. And here's the easier one, a little more up to date, and it basically says the same thing. Some good podcasts that I like, EM Crit with Scott Weingart. He's a ER physician slash intensivist in New York. Simply outstanding, just the best I've found. He has hundreds of podcasts on trauma, intensivist type stuff, ER type stuff, critical care type issues. Some of the others are ER as well as trauma, core EM, EM basic, EM wrap, really good. ER cast, I like. Rebel cast is outstanding. The recess room, total EM, easy to find. Just do a search for those and they'll pop right up. And that concludes the podcast. Hope you guys enjoy it. Leave a comment. And if you find anything I need to do better, let me know. I'm really new at this, so I struggle a bit. And thanks for your time.